All right, I think we're going to get started. So we want to start by introducing ourselves. I'm Cori Poffenberger, and I am an emergency medicine faculty member at the University of New Mexico. And my interest in this topic is both as an emergency physician, but also as the parent of a medically complex child. Through my experiences with her, I kind of realized the experiences that families of patients who are medically complex have, and realized I have a lot of insight that I could share with our community about how to better interact with families and how to better provide care for these patients.
And my name's Moon Lee. I'm a clinical associate professor at Stanford, and my interest is I'm emergency medicine trained first, and then I specialize in pediatric emergency medicine. So I see a lot of these children in our pediatric emergency department.
So we're going to start kind of doing a little bit of an interactive thing, which maybe we don't need to do since there is only two of you here. The first question we had was, how comfortable do you feel caring for children with medical complexity? Mostly comfortable. Okay, great. So I think that there's obviously a pretty wide range depending on how much care you've provided for children like this and your training and experience. I think a lot of discomfort just comes from a lack of familiarity sometimes, and also from not wanting to say or do the wrong thing. And then some other reasons why people could feel uncomfortable include the effort or time it takes, because sometimes these children do take extra time because of communication barriers or just because of complexity. Sometimes people might have feelings of pity for families when families are going through a lot. And again, sometimes people just don't feel like they've had enough training or experience to really feel confident in caring for these children. So our learning objectives today are really to describe evidence-based strategies to identify medical emergencies in children with medical complexity. These children interact with the healthcare system fairly frequently, and some of the times it can be fairly routine, but how do you tell when something is truly wrong or something is truly different? We're going to identify appropriate adaptations to the clinical environment and approach for medically complex children, so especially those children like those with autism or intellectual developmental disability. What do we need to do in order to be more successful in the emergency department when caring for them? And then finally, discuss the three domains of patient and family-centered care and how they promote effective communication. So how do we partner with our patients and families in order to have them fully engaged in the process and to make it as comfortable for them as possible? So I'm going to start by just talking for a second about this article, because I think reflecting back on one of the reasons why some people might feel uncomfortable caring for children with medical complexity is that there can be a sense of pity or feeling sorry for these families. I think that's a sentiment that unfortunately can be pervasive in our specialty, and this may not resonate with you, but I think it's important that we address it. So this was an article, it was a perspective in the New England Journal, and it was written by an emergency physician, and she talked about taking care of a child who had been physically abused and came into the emergency department quite injured, and she basically saved the child's life. But the child went on to have a permanent disability. And so then she would see the family come back with the child to the emergency department for other medical issues after that. And she always wondered whether she had done the right thing, like whether she should have saved this child because now this child had this permanent disability. And what resonated with me was the fact that the family was always very grateful to her and said, "Thank you so much for saving our child. We're so glad she's here." And yet she still had the perspective of, maybe I did the wrong thing because I think this child has a poor quality of life. And so I think we have to be very careful that we don't allow judgments like that to seep into our care when we're providing care for these children. Because studies actually show that both families and health professionals underestimate the quality of life when you compare it to patients' own assessments. So patients with various chronic health conditions and disabilities consistently rate their quality of life higher than their own family members or their doctors will rate them. And so we just have to be careful to keep that in perspective. So who are the complex kids? So there's kind of two buckets of kids we are talking about, and we're going to focus on the 0.5%, the children with medical complexity. But children with special health care needs comprise about 13 to 18% of children in the United States, and they have one of the following: the need for prescription medication, the need for medical care, functional limitations, specific therapies, or behavioral treatment or counseling. In contrast, children with medical complexity pretty much have all of those things. So they have the need for medical care, multiple needs across different domains, and at least 2 visits to specialists in the past year. So here's a diagram that kind of shows what the children with medical complexity and their families are dealing with. So there are substantial family identified service needs that have significant impact on the family. So that can be from financial strain to time constraints in terms of being engaged in therapies or taking the child to different appointments. Chronic conditions, those things that are diagnosed or can be unknown but suspected, and may be severe or associated with medical fragility. Functional limitations, which may be associated with technology dependence, things like G-tubes, tracheostomies, and BP shunts. And then healthcare use, there's high resource utilization and the necessity of involving multiple service providers. So as you can see, these children and their families obviously have a lot of challenges and many ways in which they are interacting with the healthcare system. And so what are those challenges? There's intensive hospital and or community-based service needs. So they might have a need for physical therapy or social work coordination or case management. Reliance on technology, polypharmacy, and or home care. Sometimes these children are on many, many medications. Risk of frequent and prolonged hospitalizations, which can lead to high health resource utilization, and the elevated need for care coordination. And I think, the challenge for these families is there's just multiple moving parts in many different directions, and it requires a lot of time and effort to coordinate. And so the impact on families can be significant. In one survey, more than 50% of families reported financial problems or that a family member had stopped working because of the child's health. And almost 50% reported at least one unmet medical service need. So whether that's a specialist referral, that's hearing aids or glasses or mobility devices, it's occupational therapy, physical therapy, those are all unmet medical service needs that these families may experience. And most families have at least 10 physician visits and out-of-pocket health care costs of more than $1,000 annually. And in the study of all children with special health care needs, medical complexity was actually the largest driver of inequity rather than income, language, or race. So even families that had greater than 400 times the poverty level of income, they still experienced these challenges of unmet health care needs, even though they had much more in terms of resources at their disposal to try to address that. So I think it's important to keep all of that information in mind as you're interacting with these families and think about the ways in which you can help ease the strain or the challenges that they're experiencing. And then I think it's important to know where these children with medical complexity are seen. So if you look at all pediatric emergency department visits, children with medical complexity make up 20%. And if you look at all ED visits by children with medical complexity, the majority of them are seen in a general emergency department, almost 70%. So everyone in our specialty is going to be taking care of children with medical complexity when they work. All right, so I'm going to hand it over to Moon.
We're just going to go through 3 cases to talk about specific issues that face children with medical complexity and some tips on how to optimize their care. So first case is a patient, a 5-year-old female who comes in, has a history of prematurity, CP, and BP shunt, and mom is asking for an evaluation. Yesterday, the patient was a little bit less responsive than usual. Today, almost seems back to normal, but not quite, slightly less energy. But they're going out of town tomorrow, so she kind of wants like a quick check before they go. On exam, she has normal vital signs. She's not really distressed. You can palpate the BP shunt. It's palpable. The valve will compress and refill. But she does have this slight disconjugate gaze, but she's tracking and looking around. Now, some questions that you might have to ask yourself for this case might be like, what's her baseline status? Is this her normal baseline? Is this disconjugate gaze new or old? And mom tells you, oh, this disconjugate is old. She always has a little bit of it. It doesn't seem more severe today than before. And because she has a VP shunt, another really important question is about the VP shunt. When was it placed? Is this her original VP shunt? Is it a VP shunt that's been revised recently? Because that will change her risk of having a shunt malfunction. So these are kind of the general workout options that you may consider. You might consider asking mom to say, oh, she looks fine. If you think she's almost back to baseline, just come back if things change or get worse. You may want to consider consulting neurosurgery. You could order a rapid MRI brain and shunt series or order labs. And in this case, just to review VP shunts very quickly, so VP shunts basically are placed in children for when they have hydrocephalus. There's a blockage with the CSF flow, so the ventricles get very enlarged, which causes increased pressure on the brain. So what the shunt is doing is bypassing this blockage, and often the shunt will either go into the atria of the heart or into more commonly in the peritoneum. And this is what a VP shunt looks like. There's like this reservoir here that you can often feel on the scalp, and you can sometimes pump it, and usually this shunt tends to be a one-way. Now, common symptoms with VP shunt malfunctions, it kind of ranges. You can have vomiting, headache, changes in mental status, or a slight change in behavior. If the patient's old enough to talk to you, they'll tell you they may have vision changes. They can complain of neck and back pain. If they're a very young infant, you can palpate their fontanelle and see if it seems very full. And some children will actually get sunset eyes from the increased pressure related to the VP shunt. VP shunt malfunction happens because of multiple causes. So this is a CAT scan of a child that had a VP shunt malfunction. So you can see the hydrocephalus, and you can see the shunt here. These are like examples of what the shunt looks like. So VP shunts can malfunction because there might be a mechanical obstruction. Maybe some of the choroid plexus is blocking that shunt. The shunts can get infected, especially in the post-op period. Sometimes you'll get a CAT scan and the shunt is no longer going into the ventricle, so that's another common cause, dislodgement. And because these VP shunt catheters go into the peritoneum, sometimes with constipation, that can also block the VP shunt. Sometimes as the shunt is draining into the peritoneal cavity, you can develop a pseudocyst of CSF fluid that can eventually cause blockage. Rarely, but every once in a while, the VP shunt can perforate the bowel. And another interesting dysfunction is called kind of slit ventricle syndrome. Sometimes the VP shunt will overdrain, is too active, and so instead of enlarged ventricles, you'll actually see like almost collapsed ventricles. There's actually another definition of slit ventricles where if someone's had a VP shunt from when they were a very young child, that brain has always had a shunt in place, and so the ventricles never became very plastic. And so even when there is a shunt malfunction, they'll never get hydrocephalus, and they'll just always have what looks like split ventricles or normal-sized ventricles. And that's just because the brain never learned to expand and contract because they always had this shunt their whole life. So the ways we diagnose VP shunt malfunction, our primary tools are CT or MRI. So at most places, people use CAT scans, but as we're trying to reduce the amount of radiation to children, we've moved over to using more MRI. And you can get a quick brain MRI probably within 5 minutes. The whole study will take about 3 to 5 minutes. And it doesn't give you as much detail, but it will give you the basic size of the ventricles. And often people forget, but shunt views are also very useful. These are just plain x-rays of the shunt, and it goes all the way from the head down to the abdomen. And in this example, you can see that the shunt in the brain has actually coiled upwards. And so you're not actually seeing the VP shunt, which normally would be a straight line coming down here, but you're not seeing that because it's been coiled up in the brain. So tips for this type of case and presentation is that VP shunt malfunctions can be subtle. They don't always have to have headache, vomiting, altered mental status, and so it's really important to get the imaging on pretty much every child that comes in with any complaint besides like a broken ankle or something, any complaint that you might think could possibly be related. So in our patient, this is their MRI imaging where you can see like the catheter is no longer in the ventricle. And I think often we we kind of assume like, oh, this must be their baseline, or and like mom thinks they're almost back to normal, so I don't have to do any more further investigation. But actually, you really need to think about what are some things that will cause a change in behavior in children. Why are they so irritable? Why is something different? Why are they having these breakthrough seizures? And just remember, like, what they're trying to tell you with their change in behavior is a type of communication. So the children may not be able to verbalize why, like their head hurts or they're having vision changes, but their change in behavior is another way of telling you that something is off. All right, Cori, please.
All right, So I'm going to do case 2, and the chief complaint is, again, behavioral change. This is an 8-year-old male who has autism spectrum disorder and ADHD. The history that mom gives is that he has been more agitated for the past 2 days, and he threw up twice, but no fever. On physical exam, you know these vital signs. He's a little tachycardic. He's crying and restless, agitated, walking around the room. You have trouble getting him to lie down to palpate his abdomen, but when you do, you think maybe he seems uncomfortable. And then neuro, he's moving all extremities. He's ambulatory, symmetric face. So some of the questions you might be thinking are, how does this child communicate? And so that's a question that you should always ask parents is, what's his primary mode of communication? Does he speak? Does he, have any sort of assistive communication things he uses? Does he, gesture to you? Like, what is his usual typical communication? And then thinking about how we might be able to adapt our clinical exam, our environment, in order to make the child more comfortable, so that we might be able to get a more thorough evaluation. So let's talk about autism for a second. So autism spectrum disorder really affects people in a variety of different ways and can be, there's a wide range of manifestations. But it's a neurological condition that affects the way a person experiences and interacts with the world. So there are typically impaired social interactions and difficulties with language. And then there's the other side, which is this kind of repetitive behavior and restricted range of interest. So you can see like any one child with autism might have more of one than the other, and both of those things affect their expressive language level. So if you think about the emergency department, it's pretty much the worst place in the world for a person with autism, because they really don't do well in unpredictable and chaotic environments. Sometimes a lot of noise or new people can really be overwhelming for them. And so if we think about it that way, we can think about the ways in which we might be able to modify that environment to make it more comfortable for them while they're with us. And so first of all, we want to involve the family. So again, how does he normally communicate? How can I communicate with him? And then also, utilizing that parent and caregiver expertise. So what do you think is going on with him? How can we help him best? If he's really agitated and uncomfortable, you can ask, has he ever needed medication to help him, undergo medical testing or medical procedures? Do you have any other concerns? Like, what do you think is going on, and how else can we support him or you? So sometimes, for family members of children with medical complexity, they've been through this many times, and they'll say, okay, well, this is what we usually do. We give some Ativan, or, if we just get him his iPad, he'll be fine. And so it's a wide range, and I think that that's where, like, the family member can really be a valuable tool for us. And I think the other mistake we often make is that we think that a child who maybe is nonverbal isn't able to communicate at all, and we don't even try, and then that can be a source of frustration and agitation for the patient and also for the family. And so, making the assumption that there is some way to communicate with the child, and ask the parent. And then if they say no, there's really no way, then you know. So these are some techniques that can be helpful when caring for a patient with autism spectrum disorder, or I think other intellectual disabilities. So speaking calmly. So again, not speaking down to the patient, age-appropriate communication, but, maybe a little bit slower and calmer than you might be otherwise. Using visual aids, always telling the patient what you will do before you do it, and keeping staff caring for the patient to a minimum. So I think one of our pitfalls is our failure to be thorough in history examination or testing. So in a child like this who's uncomfortable with the exam and who's agitated, we might be tempted to just not do portions of the exam. Maybe we wouldn't look in his ears, or we wouldn't, do a GU exam, or whatever it is. And that can be our pitfall if we don't figure out a way in which to do what would be appropriate testing. So an evidence-based approach to children with autism, again, some of those things we just talked about. So speaking slowly and calmly, be concrete and use visual aids like this when needed. So this can be super helpful to point out to them, okay, this is what we're gonna do, because sometimes they may not understand all the words, but if they see the picture, they understand. Rephrase, and often switching to more of a yes-no when you're asking questions can be helpful, because their receptive language may be better than their expressive language. They may totally understand what you're saying, but they may have trouble expressing it, what they want to say. Tell them what you will do before you do it. Again, don't insist on eye contact, because sometimes, especially for kids with autism, that's uncomfortable, that social piece. And then in terms of modifying the environment, so try to move them out of the waiting room quickly if you can. Try to put them in a private room. These are things that sometimes are challenging in our environment, but if you can. Limit staff caring for the patient. So I think, sometimes when we have these children with medical, this is not specific to autism. And autism, I would say it's important to limit staff because sometimes they don't do well when multiple unknown people are interacting with them. But I would also say for other families and children with medical complexity, sometimes, at teaching institutions, we're tempted, oh, this is interesting for the medical student, let's go have the med student see the patient, and then the resident, and then the attending. But I think that's actually really challenging, especially if these families have a lot of medical interaction. They're kind of tired of telling their story over and over, and sometimes that can come off as being difficult or not wanting to participate in education, which I don't think is the case, but I think sometimes you have to kind of read the room and realize that they've had a lot of healthcare interactions and maybe they're not in the best place. But for patients with autism, I think it's helpful to say, okay, we're gonna maybe just have the resident attending and one nurse, and limit the number of technicians and other people who might go in the room. And then if you work at a place that has child life, they can be helpful in providing resources. There are things like these sensory machines, which help some families for children with autism, where they can, just the lights and the bubbles kind of distract them and calm them down. Again, things like iPads or movies, various other resources that your department might have to kind of help you engage with the child with autism and get a more thorough exam. So another pitfall, I think, is failure to treat pain, and sometimes it can be difficult. And obviously, a child who isn't verbal to understand is, what is the cause of this behavior? Is it that the child is in pain? So, there are many different scales, visual pain scales that you can utilize. For a child who could point, you could try something like the Oucher scale or, the classic FACES scale. There's also things like the FLAC scale where you can rate based on, what the child's behavior is. So if they're, frowning and crying and kicking, agitated, they would be in the higher levels of that scale. So that's the FLAC scale. There's also this, which families can customize. So if there's a family who is frequently interacting with the medical community, you can ask the caregiver to fill this out. So they might say, okay, this is what my child looks like when they're comfortable and not in any pain, and when my child is in a lot of pain, this is what they do, they are screaming loudly. And so the families can be a good resource in that way too, to say yes, this is what my child behaves like when they're in pain. And then thinking about agitation, we would try to use all of these tools that we have in terms of modifying the environment, modifying our approach, making sure the child is comfortable. But sometimes we do need to use medication for agitation. And again, if you're going to need to use medication and there's a caregiver present, I would certainly engage with that caregiver and talk about the reasons why you might want to use medication, ask if there are medications that have been helpful for that child in the past. And sometimes there may be home medications that they use that you could maybe give a little bit of an extra dose of, depending on the medication. But in general, for anxious or just generalized agitation, I think benzodiazepines or hydroxyzine would be your first line. If it's more aggression or dangerous behavior, you can look also at the atypical antipsychotics like olanzapine would probably be first line. And it's nice because you have the disintegrating tablet or you have IM options for that. And then just remember that if you end up needing to give two things, the benzo and the olanzapine have to be separated in order to avoid sedation. Okay, so in our case, once we were able to engage with our patient and get a better exam, it did seem like he had abdominal tenderness. So we went ahead and ordered an ultrasound and found this, which is consistent with acute appendicitis. So I think another take-home point from this case is to respect and use family expertise. I think it can be a little bit of a careful balance. You don't want to overuse it because sometimes families might feel like they're being required to do everything or to provide all the information, but they also have a lifetime of lived experience with their child and with their child's condition, and they may have very valuable insight that if you don't engage with them and don't, try to get that feedback from them, then you're going to make your life and the child's life much harder during that encounter. And then anchoring on the underlying diagnosis as the etiology for the presentation, I think, can be a very dangerous thing with children with medical complexity. So, a child with autism spectrum disorder who presents with a change in behavior, you might be like, well, the child has autism, of course they're having agitation. But again, that's important to listen to families and say, when they say my child is different, this is not how they normally are. And then also just to assume that there might be a medical etiology until you've proven otherwise. And so, studies show that problem behavior in patients with autism spectrum disorder may be the primary or sole symptom of an underlying medical condition. Okay, third case.
All right, last case. So we're going to talk about G-tube issues, because this is a common complaint that we see in the emergency department. So 14-month-old female, she had hypoplastic left heart. She's status post bidirectional blend. And she's coming in because yesterday her G-tube fell out. She came into the ED, it was replaced. But today, when mom's getting the home meds and flushes, the patient's now crying and appears to be in pain. Here are the vital signs. The patient's a little bit tachycardic. The blood pressure is a little bit on the lower side, and the O2 sat is low, 83%. She's awake. She cries with the exam. Her abdomen is very distended and tender to palpation. You see that the G-tube is in place. There's no surrounding swelling or erythema, but she is very pale, and her cap refill is greater than 3 seconds. So what is happening here? What are some things that you're thinking about for this patient? So things that we're thinking about with those abnormal vital signs are, is this dehydration? Are they dehydrated because the G-tube isn't working well and now they haven't been able to get their home feeds? Could this be sepsis? This patient has a very complex cardiac history, so is this cardiogenic shock? Or now with this G-tube being replaced yesterday, is there a false tract that's been formed? So what you do is you replace the G-tube, and after you replace it, the family just wants to go home. They don't want to stay, but you want to get an x-ray. And the mom's asking you, well, why do I need an x-ray? When I go to clinic, in the GI clinic, they replace the G-tube all the time, and we never have to get an x-ray. Why do I have to get an x-ray here in the ED? And just thinking about, how do you navigate this complex question, right? Because mom obviously has prior experience with healthcare providers. They don't typically get an x-ray. Why do we need an x-ray now in the ED? And I think in order to help this difficult conversation, these are some key things that you can think about. One, you want her to participate in the care. She obviously knows much more about this patient than you do. So asking her to participate in the care, asking her what has been done in the past for G-tubes. Has the G-tube ever been false tracked before in the past? You want to make sure you share your information in a very timely manner. So the minute you get more information, well, I saw in the chart that this happened, and now this is what the x-ray looked like from yesterday, making sure you share all the information that you have so that everyone's on the same page. And then it's just very important to collaborate and work with her to make shared decision-making on what the next steps are going to be. And I think the overarching principle here is that you really want to treat this family with dignity and respect and not dismiss her concerns because she's not in healthcare, because she obviously knows her child very well. And another thing to keep in mind is that sometimes families may seem like they're being difficult, but they're not really. It's not necessarily that they're being difficult, it's that they often have PTSD from prior experiences because they are such frequent users of healthcare resources. So a lot of things can go wrong with the G-tube. They can get clogged. You can have G-tubes that are leaking every time it's being used. The site can get infected. Sometimes the G-tube can push up against part of the stomach and cause a gastric ulceration. Sometimes the G-tube balloon is big enough for it'll cause gastric outlet obstruction. And the most common reason why we see children in the ED is because this G-tube gets dislodged and now you're supposed to replace it. So I think with this mom, what I would do is start by asking some questions like, when was this G-tube placed? Has it been more than 4 to 6 weeks or less than 4 to 6 weeks? If it's been less than 4 weeks, then you really should have surgery replace it because it's the likelihood of a false tract forming or not being able to get back in is very high because that tract has not been formed very well for very long. You want to know how long it's been since the G-tube has been out. If it's been out more than 8 hours, the likelihood of that G-tube going back in is very small. And the longer a G-tube has been out, the less likely it's going to be successful that you're going to get it back in. It's also important to know what size the G-tube is and what type of tube. So there are a lot of different types of G-tubes, but the most common things that you want to know is you want to know the diameter, so what's the size French it is it 16 French, 12 French? And then the length of the G-tube is really important, because if the patient has a G-tube that's length is like 1.5, but in your supply room you only have a G-tube that's a 1 centimeter, it's not going to matter. That G-tube will not fit for this patient and it's not going to work. And so often the strategy that you can use for when a G-tube has been displaced is you obviously want to put something into the stoma, and while you're looking for the supply, if the parent didn't bring it in, what you can do is just put the smallest size Foley that you have in your department. So if you have 6 French, 8 French, any size Foley, just start putting it into the stoma. And then what you can do is you can just dilate up. So if you start with an 8 French, you can move to 10 French, 12 French, 14, 16. And once you get to 16 French, you actually maybe want to go one size above it. So if you're trying to replace a 16 French G-tube, you want to actually go up to an 18 French, because that balloon adds a little bit more resistance. So you just size up to one above the G-tube that you're trying to replace, and then you can replace it. And I think another key thing when you replace G-tubes is that this volume that goes into the balloon, this is actually really important, that this volume is filled with just plain water and not saline, because saline will precipitate and will leak out and corrode it. So you're just supposed to use regular plain tap water, or sterile water is fine too. And often the amount is roughly 5 mLs that goes into that balloon. So once a G-tube's been dislodged and you've replaced it, often we do a gastrograph and push to evaluate and make sure that it's in the right spot. And on this x-ray, you can see the rugae of the stomach. So you're pretty sure that that the G-tube has been replaced, it's not leaking, it's in the right spot. The incidence of misplacement is actually very low. It's like 1 to 2% maybe. But you can think about what happens if it does get misplaced, and it's going to cause peritonitis. So in this mom, we just explain, like, this is now the second visit for G-tube issue. Let's just get an x-ray to check it. So this is what this patient's x-ray looks like. And you can see there's distended bowel gas, and but otherwise there's contrast in the stomach, and so our radiologist read this x-ray as normal. Surgery also saw this patient, so it's just very important to communicate with the subspecialist. So surgery also saw the patient who thought, okay, it's in good position, but now this patient's decompensating in the ED. They became more tachycardic, less responsive. We called cardiology to see the patient. We started pressors, IV fluids, and admitted to the PICU, but ultimately died from peritonitis. So what happened in this case? Well, I think one was, even though we were communicating with the surgeons about this case, maybe communicating a little bit earlier about that the patient was in the ED, now this is their second visit, instead of trying to replace it. I think often we get one view x-ray of the G-tube, but sometimes you do need 2 views if it's not really clear what's happening with a contrast. I just want to show you like a photo. This photo here is from the first visit, and you see contrast in the stomach, it looks like. And this is the photo from the second visit. And you can see that they both basically look about the same, right? And if this contrast from the first visit was truly in the stomach, on the second visit you would expect it to be somewhere else in the bowel, but you only see it isolated in one area. And after this case at our institution, we actually institute a protocol where now they get more than one view of the x-ray just to really confirm placement, because if you had gotten like a lateral view, you would have seen that it's all like in a false track, not in where it's supposed to be. So I think it's just very important to remember that children with medical complexity are very fragile and decompensate very quickly, so there's very little room, and you really have to pay attention to them. You can't really think like, oh, that's fine, that'll get better, because it often won't. Cori's just going to go through some of our summary points.
All right. So our take-home points really are that medical complexity is a significant driver of unmet healthcare needs and financial strain for families. So remember that, and when they're in the emergency department, engage with them. Try to figure out how you can help them if there are resources that you can help connect them to. And then remember that identifying medical emergencies can be challenging, but if you take an evidence-based approach, you establish the patient's baseline by asking the mom or the other caregivers, be thorough, listen to parents, and then remember that all behavior is communication and that changes in behavior do have a medical etiology until proven otherwise. Adapt the clinical environment and your approach to increase success in patients with autism or other intellectual disabilities. I think we need to be flexible and not rigid in terms of the way we do things. And then partner with families using dignity and respect, collaboration, and information sharing. I think if they feel like you're respecting their voice and you really want to engage with them to do the best for their child, then sometimes those interactions, which may be contentious because of parents' prior medical experiences, can be turned around and they can see you as an ally. So I think that's all we have. We'll take any questions if you have them. Yeah. Yeah.
I'm a EM trained doc, but I'm also did pediatric emergency medicine as well. So I work primarily in the PTR.
Mm-hmm.
And one of the difficulties that we have is families with complex medical conditions. Some of them, for whatever reasons, the subspecialty service has really signed off on them. They get care at another institution.
Mm-hmm.
And when they come into our institution, because they live close to where I am, the other institution is maybe like 20 miles away. And then I'm always worried about something quote bad happening, and then I always get the consultant involved. In this case, it's the neurosurgeon, the VP Shunts. And they always say, well, it looks okay, send them out. But I'm not so confident about that. And it always leads to some friction about what's going on. In one case that I had, it turned out the VP Shunt was malfunctioned, and the mother was very insistent. Thank God she was very proactive about it and said that this is something different. And I impressed upon the neurosurgical service to have to look at this kid. He wound up coming down again. I guess my question is, how do you kind of work with the dynamics? The family wants the patient to be seen, but they don't like us. And the neurosurgeons say, unless the patient is in a critical condition, they don't want to see this patient. But in the ED, I'm worried something bad that they won't come here unless they thought something was going on. How do I kind of balance all these competing interests?
Yeah, I think that's a challenging situation. I think, from my perspective, like patients with VP shunts, as you said, like even if imaging looks okay, I would have a neurosurgeon see that patient every time. And there's too many cases, like up to a quarter of cases can have normal imaging findings with a VP shunt malfunction. So I would just, be like, sorry, you got to come see the patient, even though maybe they don't follow with you. Like this is within neurosurgery scope of practice, and I need you to see the patient. If it's not a situation in which you have an obvious malfunction, I would still want them to see the patient. And I think, trying to understand the family's perspective in terms of why they go somewhere else versus there, those things can be helpful, but maybe not necessarily in the acute setting for that particular case. Did you have any other?
Oh, I think
ideas?
the only other thing would be to maybe consider admitting for observation. Like if you can't get the neurosurgeon down to see them, the family says, no, there's something wrong, maybe admitting for observation if you have that capacity, just to make sure that they're in a safe environment where if they needed surgery, they're right there already in the hospital and they're not driving back and forth.
Yeah, we did entertain that option. And there's a lot of pushback from my hospital service. What the neurosurgeons say, because they don't want to be taking care of a patient potentially so sick, which we didn't know. And then, the hospital's uncertainty or lack of confidence is rightly so, in my opinion, because they don't know what's going on. They're not neurosurgeons. That's why we needed them.
Yeah. And I guess the other option is if they do have a neurosurgeon that they follow and who takes care of them, you could see if you could transfer them and be like, this is your patient that you follow. They came to RED, but maybe, mom's uncomfortable. Would you be willing to take them and transfer? Yeah. And I think then families who are not, in healthcare don't really understand these challenges that we experience when people get their care one place, but then they come to a different emergency department. We see this all the time in various conditions. And since I'm in healthcare, I understand, but then I think sometimes we do families a disservice by not educating them about that at some point, to be this is the challenge if you get all your care here, but you come here, and obviously if it's an emergency, they need to go where they need to go to the closest place, but helping them to kind of understand those dynamics so that in the future those interactions maybe go easier.
And the shunts are getting smarter, and I've noticed a lot of the shunts you can put a device near them to figure out what the settings are. So it's kind of nice now that it's not like just like a shot that you can't tell any you can't get any information from. So now that they're getting a little bit smarter, like sometimes it's nice when the MRI happens because it often deactivates the shot. And then neurosurgery has to come in just to reactivate it. So it's kind of like,
Yeah,
it's
that's nice. Reset it. Yeah.
And then they're like, oh, it's good too, because then I can check the settings while I'm here anyway. And so I'm like, oh, that's great, because that's something that we didn't have before, but now it's kind of changing with the newer shunts, which I kind of appreciate.
Yeah.
That one, you can check the settings without like doing massive surgery, and two, that you have to reset it after MRI. For
Actually, that might be a good way to kind of manage it.
Yeah.
What I wound up doing is, I wound up doing two tracks at the same time. I wound up imaging the child, doing something bad was happening, but I also started the transfer process,
Yeah.
not really know what's going on.
Right.
My neurosurgeon got really angry at me and said that, the patient be transferred to me, you thought something's going on, why didn't you image the kid?
Yeah.
So I wound up imaging the kid and calling the
Yeah.
transfer center, whichever's the path that get the most optimal care at that point. I kind of lucked out because the neurosurgeon and the mom was convincing enough that I said, hey, something's going on. I said, oh, it doesn't sound right. They ultimately came down. But you're right about about looking at the smart
settings.
I think I may have to use that as my advantage.
Yeah.
It needs to be kind of reset or something.
Yeah, and I mean, it's uncommon, but the sometimes like the shunt settings can get off just by like magnets, and so like if they check this, like if they're having symptoms, sometimes it's helpful to check the settings before they get to MRI even, because it might be they don't even need the MRI, because you might be like, oh, your shunt settings are all messed up, let's fix them, and maybe you don't need imaging at all, So that's another thing that you can kind of engage them on. Most kids these days have the programmable shunts, but not everybody does. So.
How does that kind of go out of whack?
I mean, it's rare, and they're like, the valves that they have now are like more resistant, supposedly. But my daughter has a programmable BP shunt, and we had one time where like she was having symptoms. We went in and they checked the settings before the MRI, and they were like, your settings are all off. And I was like, how did that happen? I have no idea, And we're always really careful being like, no magnets anywhere nearby, but it happens, I guess.
Yeah.
But it's rare.
And the newer shunts, you can't do the pumping. Like the old shunts, you could always pump. I mean, you can pump, but it doesn't give you as much information.
Yeah,
anymore.
my neurosurgeon is around.
Yeah.
To do that. They
Yeah.
don't want this stuff.
Yeah.
Yeah.
Yeah, yeah.
So we don't.
Yeah, I think the pumping thing's kind of going out of fashion.
Yeah, I mean, I guess like if it's helpful if like you can feel the valve and like it's not compressible at all. You're like, that's not normal, but like it can still be compressible and have a shunt malfunction. So, yeah. Interesting. All right, thank you. Thank you.